I'm here with my co-interpreter, Ileana, and we just wanted to gauge potential need for interpretation. Is there anyone here who's not fully comfortable with English, who might need interpretation into Spanish? Bueno, buenas tardes, mi nombre es Lluvia, estoy con mi colega Ileana. Nada más queríamos tener una lectura de si quizás necesite la interpretación, si hay alguien aquí que no se siente completamente cómodo en inglés y pueda necesitar la interpretación al español. ¿Usted? ¿Tiene su aparatito?
No,
No, aquí tenemos uno. Here.
Okay, we'll go ahead and get started. Good afternoon, everyone. Welcome. Really excited for this panel today. Excited that you all could join us. We're going to be talking about who owns your care, how consolidation, private equity, and really like profit motives are reshaping health access, quality, and affordability. And so we know across the country, we're seeing major shifts in how our healthcare is being owned and being delivered. We have hospitals, doctors' offices, nursing homes being bought up by larger companies, merging together, creating these really big health systems. And there's even private equity firms coming in to make profit off our healthcare system. And so we'll talk a lot about the issue of consolidation and what that means and some examples from our lovely panelists here. But really it's about when doctors, hospitals, clinics are being bought and merged together. It's called consolidation. Things are being more consolidated. And these decisions are often made behind closed doors, but they have real consequences over the care that people are able to access. It could be more expensive, fewer doctors available in areas, especially in our rural and low-income communities. People are left with fewer options. So today we'll explore this issue of consolidation and who's benefiting it and how it's impacting care and what we can do about it as patients, workers, and communities. And so we have three incredible panelists today that I will introduce right now. We first have Lynette Molomeli. She serves as Executive Director of the Madeira Coalition for Community Justice, MCCJ. It is a nonprofit organization dedicated to advancing equity and empowering underserved communities in California's Central Valley. Under her leadership, MCCJ has strengthened its role as a catalyst for grassroots advocacy, civic engagement, and policy change in the areas of environmental justice, economic equity, and public health. With a deep commitment to social justice, Lynette has spearheaded initiatives that amplify community voices and drive meaningful systemic change. She's also collaborated with local and state leaders, such as California State Senator Ana Caballero, to advocate for consumer protections, reforms, and equitable access to critical resources. So welcome, Lynette. We also have on the left, Ian Lewis works on health policy and other matters for Unite Here, the largest union of hotel, restaurant, and casino workers in North America. He's been with Unite Here for 26 years, most of that time based in Northern California. The big majority of Unite Here's members and their families are immigrants and people of color. Many access the US health system for the first time through their union bargained health insurance plans. Ian is a trustee on one of the biggest of those plans in California and has advocated in Sacramento for health reform, especially cost control, for a dozen of years. He's the Assembly Speaker's appointee to the Office of Healthcare Affordability Board. And relevant to today's conversation, many of the companies that Unite Here struggles with to fund health coverage for workers and their families also happen to be owned by the same investment firms that are buying up and consolidating our healthcare industry. So welcome, Ian. Lastly, we have Sophia Tripoli. She is a strategic, innovative health policy thought leader and oversees and leads Family USA's strategic development and framework on all aspects of its health policy priorities, including guidance on federal and state health policy that will improve healthcare and health for all families and individuals in America. Prior to this role, Sophia led Families USA's work on value initiatives that focus on reorienting health system to deliver health, lower healthcare costs, and on forwarding consumer policy agendas to improve healthcare delivery and payment systems. Sophia represents Family USA on the board of directors for the Healthcare Transformation Task Force and serves on the Accountability Care Action Collaborative for Health Payment, Learning, and Action. So welcome, Sophia. So to get us started, Sophia, I'd love to turn to you. Just how did Families USA, which is a national consumer organization, become interested in this issue of consolidation? Why is this a consumer issue? And can you help us understand how consolidation is changing healthcare?
Sure, absolutely. First of all, hi, everybody. Good afternoon. It's really, really nice to be here. I'm honored to be on the panel with you guys and to be here in partnership with CPEHN. So Families, just very quickly, Families USA is a national consumer advocacy organization. The mission of our organization is to fight to make sure that every person living in this country has the high quality, affordable healthcare and the health that they deserve. It's an organization with nearly about 40 years of history and has been operational for a long time. And has mostly been known as the organization at the national level that's been fighting in the front lines to expand coverage. Those on the front lines of the fight for the Affordable Care Act, expanding Medicaid and the expansion of Medicaid in nearly every state that has expanded, expansion and protection of the CHIP program, the Children's Health Insurance Program, and all kinds of other coverage innovations and coverage expansions of healthcare. And about 7 years ago, we had a conversation. We started having these conversations about healthcare costs. Healthcare costs are increasing. We hear that all the time. Healthcare costs in the United States of America are increasing faster than our gross domestic product, and that we're spending all this money on healthcare, and yet our health outcomes are not improving, or in many cases they're getting worse. And we tried to figure out why that is. What are the drivers of making healthcare more expensive for consumers like ourselves, for our employers, for the federal government, for state governments? And when you start peeling back the layers of the very complicated healthcare financing and payment system in the United States healthcare, you really get a sense of what the trends are. And one of the biggest trends, one of the biggest factors that's driving up healthcare costs in our country is consolidation. Consolidation of drug companies and their ability to set whatever drug price that they want without any oversight. Consolidation of insurance companies and the ability for insurance companies to increase prices and limit access to care. And now even more hospitals and health systems and provider groups even are all consolidating. And what's happening underneath the hood of the healthcare system is that 60 years ago, these hospitals and small health plans, they used to be these charitable institutions, and those still exist. But what's happened over the last 60 years is these charitable institutions that were, staffed by volunteers and funded by donations have shifted into these mega profit maximizing machines. And that is really what is at the foundation of our healthcare system today, that these hospitals in particular, and we can talk about insurance plans and drug companies and all the different actors in the system, but hospitals in particular have shifted their business model for how they make care in the healthcare system. And the way they make money is they buy up as much competition as they can, other doctors' offices, other hospital systems, and they get bigger and bigger and bigger. And as big and bigger they get, the more ability that they have to set any healthcare price. So year after year, for the last several decades, hospitals have been gaining more and more power, and in all of their markets have been increasing prices year after year. And obviously you guys have tons of examples from California that have helped put that issue on this sort of national map for healthcare policymaking. So for consumer advocates, we realized that if we want to keep fighting for coverage expansions and to make the case for a Medicare program that's here forever, a Medicaid program that's here forever and that can rebound, particularly in this moment, for an employer-sponsored health insurance market and the ACA exchanges and all the ways that people get healthcare in the healthcare system today, we have to take on costs. And we have to figure out, how do we address this corporate greed in the healthcare system and rein it in? And so that's kind of the framework that we came just to come in to focus on the work around consolidation. And about 6 years ago, we launched a big national campaign, and we've been partnering with organizations across the country and across the states. And the last thing I'll say is, one of the things that people, I think, why does this matter to consumers? The reason it matters for consumers is in two ways, I would say. The first is that even for public programs, Medicare in particular, we're paying taxes on that. And the bigger these systems get, the more they're able to leverage some of the loopholes in how we pay for care to take more money from the federal government that we all end up paying for. So that's one way that we pay. And the other way is through insurance premiums for those of us who get their health insurance from an employer or who purchase it on the individual market. We're paying premiums, we're paying out-of-pocket costs, and those are driven by hospital and drug prices predominantly. And the more your employer spends on your premiums, the less they're spending on salary increases, on more comprehensive benefit packages. And so we're paying it at all ends, right? And then of course, and I know we'll get into this, is a lot of times when consolidation happens, we lose access to care. So some of the most critical services that our communities rely on, maternity care, primary care, mental health and behavioral health services. And those are usually the first services to go, the services that we need most access to. And so it's a consumer advocacy issue. It is right for organizing, for taking it to the state legislatures, to Congress, to fight for all the ways that we need to rein in corporate greed and sort of out of control healthcare spending.
Thanks, Sophia. Yeah, I think that appreciate that framing that we're removing choices and then companies get to dictate the prices they set, like going to a movie theater and then we have one option to buy popcorn or soda. Like that's how the healthcare model is turning into. Ian, Unite Here is a labor union that represents hospitality workers. So folks may not realize that you are also very involved in the fight around healthcare costs and issues. Can you talk about how your union got involved in this fight against rising healthcare costs and the connection between consolidation and costs and how that impacts your workers and their families?
Yeah, when you step back and think about it, it is crazy that a hotel and restaurant workers union should spend a minute thinking about healthcare, but this is America, and half of the people who have insurance through their employment or their family's employment. When workers come together to organize into a union, they fight for what working class people always fight for: stability, security, and at the very top of people's list is always healthcare. Our members, they make too much money to qualify for Medi-Cal for the most part. They make too little money to make Affordable Care Act plans meaningfully affordable. So the bargaining that they do when they organize for healthcare is really, it's all about getting that comprehensive package of healthcare benefits for themselves, their family. All of our members are in the private sector. They work for for-profit companies, and there is a dollar for dollar trade-off between healthcare and wages or pension or the other things that people want, staffing improvements and so on. For a for-profit employer, what they really care about is how much per productive hour is the labor cost. They don't care if it goes to wages or healthcare or pension. It is just what's the total amount I have to pay to get somebody to make money for me as an employer. And that makes for some very perverse dynamics. Regular real world experience that I had, you sit down at a negotiating table with an employer where workers have just come together and fought to organize a union. And the employer might have had a high deductible health plan that just barely met the minimum for the Affordable Care Act. And workers are fighting, sometimes striking, for comprehensive healthcare benefits. And the employer is looking at the math here, and they look at the difference between what they're paying now for a high deductible health plan that few people take up and the cost of comprehensive healthcare benefits. That difference comes straight out of their cash flow. Coming out of their cash flow, that reduces the value that their company is worth when they want to turn around and sell it to another investor, often by 40 or 50%. So you think how hard an employer is motivated to fight to defend 40 or 50% of the value of their company. It's no wonder that healthcare is at the heart of so many strikes and lockouts and other labor disputes in this country. In terms of consolidation, there's a very strong relation between the consolidated market and high prices. It's all about market power. For those of us who get healthcare in what's called the commercial market, that is the market where the government doesn't say what rates get paid. The government says what rates get paid for Medicare. It says what rates get paid for Medi-Cal. It's the commercial sector where we let market forces do their thing. And, healthcare isn't like an ordinary commodity. When hotel prices are too high, people just don't travel. We don't have that option with healthcare, right? So they have the hospitals, the insurance companies, they're in command when it comes to negotiations. We have very, very little leverage. Even our biggest health plans or health funds that buy these plans. It's especially bad in California and especially bad in Northern California. The Bay Area pays for healthcare in general 80 to 90% more than the US median for healthcare. And remember, the US pays twice as much as many other rich countries for healthcare. For hospitals, we pay double the US median in the Bay Area, and just a few hills over from you, Lynette, in Monterey County, they pay 1.5 times more than the US median for hospital care in Monterey County, because there are 3 hospitals that just have a total stranglehold on that market. There's one hospital where our funds, our members' money, pays 6 times what Medicare thinks is a fair rate for hospital services. But again, where else are we going to go? Just want to wrap up. I want you to think about the people you work with every day. They're probably a lot like my union's members. Think what $250,000, what a difference that amount of money would make to any person you work with. That is how much money every single union room cleaner and dishwasher and cook in the city of San Francisco would have more in their pockets or in their pensions today if over the last 25 years, healthcare had simply gone up at the rate of inflation of everything else. $250,000 would be life-changing for our members, right? There would be no housing affordability crisis. People wouldn't be working into their 70s and 80s just to make ends meet. They wouldn't be working the second jobs. It would radically change them, their families' lives, and the community, right? The sense of security and stability in our communities. And that's why we fight.
Thank you, Ian. Yes, as Ian mentioned, the cost of healthcare are rising more than inflation over these last decades or so, which makes it difficult then as things get consolidated, they have more control over prices. And as our panelists mentioned, there's only so many options. There's no options, and you can't not choose to go get healthcare. Eventually, we're all gonna have to go get healthcare, even if we delay. We're eventually gonna get sick, have an illness, and that leaves us with difficult choices to make. So I think, Lynette, I'd turn it to you now. So with the Madera Coalition for Community Justice, we've long been working on a wide range of issues, right? From environmental justice to education, civic engagement. And then in 2023, Madera Community Hospital closed, which left thousands of residents struggling to access healthcare. How was MCCJ uniquely positioned to get involved in that struggle? And can you walk us briefly through what happened and the impacts the closure had on the community?
Sure. So the coalition has been serving the county of Madera for a little bit over 30 years. And like mentioned, the coalition has covered a wide variety of areas or issues that the community has faced. In 2023, when the hospital was going to get involved in some capacity, whether it was directly with the community. But not only understanding what's going on and trying to interpret and make sense of it, but then how do we get community to understand that this is super important information, make this accessible for the community so that way they feel like, okay, I'm understanding what's coming down our pipeline. So with the coalition, I would say what made us, what gave us an edge to really get community educated in what was happening or going to happen to our hospital specifically, but our healthcare overall in the county, was we pride ourselves on the relationship that we have with the community. It's something that we've done, like I said, for over 30 years, where we really would meet community where they're at. And I'm sure most of us hear that saying all the time, where you meet community where they're at. And we absolutely did that. And you know, if community maybe where they heard that something was coming down, or they heard that the hospital was in trouble, but they didn't help understand than just the hospital. This is something bigger than just our county. And certainly we know that that's our reality today for all of us in this room and beyond. But in a nutshell, what happened was it was really a whirlwind of, I would say, just incredibly tragic events that, as the days kind of passed, our community were absolutely feeling the effects. And that was when community kind of woke up and were like, hey, wait a minute, I don't get my healthcare here, but my neighbor does. And I have, you know, friends and family members that they rely on this hospital to get their acute care, to get just, it's peace of mind having an emergency room that's minutes away versus having to travel a half hour away, the shortest distance, to hopefully make it to emergency services. So really with the closure of the hospital and how it happened, it was kind of like a day and night sort of situation. And you can imagine a community that is predominantly Spanish speaking, low income, low resources. This is something that can feel like it's incredibly overwhelming, but it's also something that, we understood community, felt like, well, what can we do? This is above us. We have no say so in this because we didn't ask for this hospital to close down. So with the closure, and trying to help community understand the impacts of what not only the hospital closure would mean to our community as a whole, regarding healthcare, but also with jobs and how that was impacting, our local economy. So there was a lot of different aspects that the coalition really wanted to try to get in front of as quick as possible. We are not healthcare experts, but we are experts in our community, I would say. So we really utilized our relationship and leveraged that relationship and the trust that we built with the community to help understand and help educate. And certainly one of the components of that work and the intention behind the education was to organize community. And I believe that's something that probably going to have a little bit more opportunity to go in depth over, but certainly as a community-based organization that we strictly serve the county, we felt the impacts. And we do have a little bit more closer communication with local electeds and, the powers that be in the county. So we were hearing things that were going to come out, and we understood like, whoa, this is huge. And maybe if this is just put out in, our local news articles or in, the news articles in the larger town pretty close by, yeah, I mean, our community is going to read it and say, wow, this is bad. But we really wanted to make sure that the community understood how bad it was going to be. And it was an unfortunate reality, but like I said, we're not healthcare experts, but knowing that the impacts were going to be so grave, it was of the utmost importance for us to not only get involved, but also get the community involved and ready and prepared to organize moving forward.
Thank you. I think, Ian, I'll just follow up with you. So, Madera Community Hospital, it was a nonprofit hospital before it closed. Because it wasn't making enough money, right? That's what they say. It closed because it wasn't making enough money. But at the same time, I think it's confusing because we see other hospitals across the state that seem like they're making a ton of money with high prices and really healthy profit margins. And so can you just explain to us like how these different business models kind of create this environment, you know, with for-profit, nonprofit, and then private equity? And what are the impacts on workers and communities?
Yeah, I might start with for-profit, because I think the profit-driven, the market-based setting of prices is at the heart of a lot of these problems. You know, you often think like, okay, you make a little bit of profit, you run your business, you make a little profit, that's good. That's how many of us we pay our bills, we try and stay just a little bit ahead of our bills. That doesn't work for for-profit companies. If your profit margin isn't growing, investors run away from you and they go to companies whose profit margins are growing. So making profit is not enough, it has to be growing year over year over year. Private equity, what we call private equity, it's a particular kind of investment. It's not unique, but it's typically very, very big organizations will invest together with other similar organizations. Pension funds do this, very rich people do this, governments do this, endowments do this, and universities do this. They put money in a pool and they go and buy up businesses, real estate, things like that. Private equity gets a bad rap because they play capitalism by the book. They're aggressive, but they're doing kind of the same thing as everybody else, just more so. Two things really distinguish private equity from public equity, like the stock exchange-based companies or small proprietor-based companies. Private equity firms tend to buy things that are higher risk because they're looking for higher rates of return for their investors, usually in the 12 to 15% per year range. And secondly, private equity usually only invests for a short period, 5 to 8 years is pretty common. That's kind of a business model of what we call private equity. So, you know, they use some pretty bare knuckle tactics to make these kind of returns. They slash the operating costs, especially staffing. And in healthcare, staffing is everything in terms of guaranteeing good outcomes for patients. They're very aggressive about pricing. They look for markets where they can buy different companies and put them together so that they can push the prices higher. And they take out debt, and they take out big mortgages that the hospital, for instance, then has to carry, and they pay themselves their dividends. And then they leave and the hospital's stuck with the debt. None of this is unique to private equity again, but they do it very aggressively. Nonprofits, let me just say, in America, we conflate nonprofit with organizations that do good. And I'm guessing a lot of you work for nonprofits. But not every company that is a nonprofit stays true to the mission of doing good. Nonprofit is really a section of a tax code that corporations can choose to operate under. So, and again, don't get me wrong, not every nonprofit healthcare organization is like this. There are some amazing community clinics and other kinds of organizations that do incredible work and really do keep the core mission, the community-oriented mission to their heart. But I won't name names, but we all know of others that don't do that. They can't operate in a market-based environment where others are being driven by profit motives without following that model, right? They're still competing for the same staff and professionals. They're still competing for reputation, and keeping patients coming to them. They're still competing for the same bond investors that they need to borrow money from to expand. So if you have any profit motive in the market, everybody's going to gravitate in that direction. And again, that's especially true in healthcare, which isn't an ordinary commodity. There's almost infinite demand for good care. I think, I mean, you'll know more than me, but I think Madeira got squeezed by the worst of all of these forces. The rural market, they didn't have a lot of commercial payers that they could raise the prices on, like Monterey County did. We're losing patients to Fresno and elsewhere. You know, they're competing with higher priced facilities for professional services and frankly for competent management. And there's a real problem with competency of their top managerial staff there. And there was no state or regional organization to fall back on. The state doesn't right now have the ability to step in and take into receivership hospitals like they do schools. And I keep coming back to Monterey because it's such a tale of two cities, with Madera or San Benito County, where a similar dynamic is playing out right next to each other. The inequity of having hospitals being charged, receiving from us 600% of Medicare prices, and we lose an essential facility like Madera or Hazel Hawkins. It's such a travesty, right? And it doesn't need to be that way. Oh, just, you know, I have learned recently that if we were as a state to say hospitals get paid twice, let's say twice what Medicare pays, there are 150 hospitals in the state that would take a haircut. We would take money away from them, I mean, especially, for example, those ones in Monterey. 200 hospitals in the state, including Madera, will get a windfall. They would make more money. Like, if you want to end inequity, like, we got to do something like that to spread the wealth.
Thank you. Yeah, I think it's a great point of how if we're all operating this profit-driven, you have to keep growing and growing, and then everybody has to race to the bottom, whether you're nonprofit, for-profit, private equity. You know, Lynette, to turn to you. So Madera Community Hospital did finally reopen this year after they were purchased by a for-profit company, not private equity, but still for-profit. The company owns several other rural hospitals. This is their business model, to buy other rural hospitals in California and in other states too. They're expanding. Can you talk about the concerns that MCCJ had with how the sale of that hospital went down and how you organized and pushed to get yourselves in that conversation around the sale of the hospitals?
Yeah, so we did have concerns. I mean, it was public information. So one of the strategies that MCCJ kind of went with, which is our typical sort of strategy that we do when we're taking on things that are really outside of our scope, is, okay, well, who do we know in our network that not only can guide us in the right direction, but ultimately, like, really channel the work and the end goal for us, which, like I said previously, was to not only educate, but certainly organize the community regarding the hospital. So, you know, the coalition kind of took a leap of faith, and I think we were biting off a little bit more than we can chew, but we certainly were all kind of like taking a piece and giving it to, you know, the collective that was really pushing this forward. And we filed a lawsuit. Again, in the bankruptcy proceedings. Now, I want to be super clear, MCCJ had no assets in the hospital. There was nothing to be paid to MCCJ. So really our lawsuit that we filed was, we knew we were going in and it was going to be thrown out. We weren't going to get paid, you know, or a miraculous check because all of a sudden we had a lawsuit in there. We had every intention of going in and just allowing or kind of fighting for a few minutes in front of the judge to remind him that regardless of the decision of who was going to be taking over the hospital, how these assets were going to be liquidated, how people were going to be paid back, there was a community that was suffering not only the closure, but was potentially going to be, I mean, in the hands of this new management company. So with the lawsuit, like I said, it was thrown out, but that was our opportunity to really put faces and put families and put real life people, unfortunately attached to these dollar signs, and really just making sure that everybody cleanly walked away with their cut. Now, I do want to say that it was incredibly intimidating to be in those conversations or to be in those spaces. Like I said, we're not healthcare experts. I certainly am not an expert by any means, but we understood that without communities' representation during the legal proceeding, without communities' representation being put forth in front of the judge, really it would just kind of be like, who wants to take over this hospital and how can we get this cleaned up? Which we understood as the time went on that there was a lot of things that went into the closure of a hospital. But again, going back to community and really wanting to organize with intention, I would say one of the driving forces for us to really move forward with this lawsuit was hearing the discussions and the comments that the reason why our hospital closed was because our Medi-Cal reimbursement rate is so low. And because of the community, it's a low income community, that's why our hospital closed down, because we were impacted by these low reimbursement rates. And as somebody that serves the community, I took that as like, it was a huge slap in the face to hear that, you know, the community that you serve, the community that, you know, you guys are here working for, you're blaming them for the closure of this hospital. Not only was that a slap in the face, but we also don't have health care during this time. Now we're looking and we're pretty much being tossed around and just kind of being put in the hands of whoever was willing to take over our mess, because that's what was being put out there. So the intent of us getting involved in the legal proceedings, like I said, was just to ensure that the community was always in every aspect of the conversation. We did not want that to be something that was a forethought, an afterthought. I think where, looking back now, I think one of the things that as a community-based organization, when you're taking on things that sometimes do feel bigger than, you know, your capacity or bigger than, I guess, your knowledge, I think it's kind of looking back at that human aspect of what all of this means and what your organization represents, and, you know, being that nonprofit organization that stands by what they say, you know, that they are. So for us, that was incredibly important. So I would say that our strategy was just to kind of circle back and remind ourselves, what is it that we're here for? What is it that we're known for? And at what cost? If we don't say anything, if we don't get involved, who is at risk here? Who is going to go without representation? And that was our entire community. So we knew we had no other choice but to kind of throw ourselves in that race. And like I said, our lawsuit was tossed out, expected, but we were granted the opportunity to speak on behalf of community and to really share with the judge our concerns as a community-based organization, not just from our personal perspective, but at that point from community's perspective, because we were already having those conversations with community and giving them the information and letting them to decide on their own. Is this who we want to manage our healthcare? Is this what we want? Like, let's really understand, you know, what this means and how this could impact us. So I think our strategy was just keeping our community in mind and knowing that that's who we work for.
Yeah. Turning to Sophia, I think like Lynette and Ian's comments really pointing to this bigger picture question of, you know, when healthcare depends on profit, what happens to the communities like Madera that are not seen as profitable, that are majority Medi-Cal, Medicaid, that are being blamed for their hospital closing? What does the story tell us about how consolidation, for-profit ownership are playing out in these different areas, and what are the trade-offs that we're being forced to accept because of this system?
Yeah, and I think you kind of just said it too, which is, and I think Lynette, you mentioned that, I mean, I think in Madeira, it sounded like a predominantly low income, a lot of people low income, so it means they probably have Medicare, Medicaid, Medi-Cal in terms of reimbursement. So for that hospital, they don't have people with the employer, the private commercially insured individuals coming into that hospital where they can charge those much higher prices. And so they're relying on public reimbursement. And so I think the result that, part of the dynamics was that they probably were not making, there wasn't enough profit coming from that payer mix, or that people in their communities who were paying for the care. It wasn't high enough for them to keep their doors open. And so they closed, right? And ultimately you guys were successful and able to get them to reopen. But that happens all the time, right? It's like these communities who rely on a hospital system, or a system, or even an individual hospital that's not able to keep pace, has to lay off workers, close service lines, close whole parts of the healthcare delivery system that people in that community rely on. As I mentioned before, maternity services, primary care services that they don't see as generating enough profit to keep the doors open. And so they close them off. And so it leaves communities particularly susceptible to closures, like the complete loss of access. But it also leaves communities susceptible to consolidation, where another bigger system, whether it's a for-profit or nonprofit, and in this case, whether you're for-profit or nonprofit or private equity, they're all consolidating, right? And so that's really important to remember, to come in and to reopen, because they might see that the land is super profitable. And in a lot of cases, we're seeing, as Ian mentioned, we're seeing healthcare, has become a bit of a real estate agency in many ways, and is seeing profitable land and selling off land and taking out debt to generate revenue. And so it's become a very convoluted healthcare system, where the interests of people about keeping people healthy, making sure that people can get the care they need at a price they can afford, and not go bankrupt because they have a medical pill, don't have to choose between putting food on the table or going to see their doctor and to get their heart medication, are really put in these very, very vulnerable positions. And a lot of times what we see happen is when a big company comes in and buys up a hospital, even if it doesn't close, but just buys it up, we see a lot of changes happening. We see increases in prices, again, because they're all looking at this, how do you generate the revenue, the profit, right, in this market. And the business model, these hospitals are not held accountable for, am I keeping everybody in my community healthy? Can everybody afford? Their model's not based off of that. Their model is just based off of, how much power can I get, and how much can I increase prices, and how much can I turn people over in my beds? The more I turn them over and the more procedures that I have at high prices, the more revenue they gain. So the incentives in the healthcare system are completely misaligned with people and consumers, the very people that the system is supposed to serve. And so it leaves a lot of communities extremely vulnerable. And I wanted to say two really quick things about one thing about nonprofits is, as you mentioned, one thing for people to remember is that these institutions get crazy tax breaks, massive billions of dollars of tax breaks at the state level and at the federal level every single year, in exchange for that tax exempt status by federal law. And because of the Affordable Care Act, they're supposed to be, because with that tax exempt status, making investments into the communities. And yet, year after year after year shows that charity care, which is what they call it, is deeply underinvested, right? They're cooking the books to make it seem like they're doing all this stuff in the community, but actually they're building new surgical wings for specialty care so they can jack up prices, right? That is literally the business model. And so I think it's really important, we've got to be super vigilant. And I think Lynette's story is a perfect, not accepting the status quo, just not accepting it and organizing and bringing the face of human beings into the conversation. Because I'm just curious, how many of you guys have gotten a high hospital, a high medical bill at some point in the last year, or know somebody, a family member, a neighbor, a parent, a kid? Everybody has the story of how am I charged this much for this care that I'm supposedly have insurance for? It makes no sense. And I think that's just a symptom of how broken the healthcare system is. And we're paying so much money into it, but we're actually not getting out of it what we need, and what it's for that investment that we're making, we're not getting much out of it in terms of the value.
Thank you, Sophia. Yeah, I think it's so important that this is our money. either through our taxes, through our wages that they take out to pay for health insurance. Like, this is all of our money. And it's hard to see it being, almost feels like being wasted so that companies can make a profit. I'm reminded of my mom. My mom works in the Central Coast for a big nonprofit Catholic hospital. She's the person that calls people before surgeries and asks them to pay a little bit of money before their surgery. But her management is a different company. It's not the hospital. It's another for-profit company that does all the billing. And they have a whiteboard in her office of who are the top collectors each month. And the pressure to collect from people on the phone that are just trying to get their appendix, get a knee surgery, hip. She's ready to quit. People who are the top collectors get a Starbucks gift card. So that is the mentality at a nonprofit hospital that has monopolized really this part of the Central Coast, and it's supposed to be a Catholic hospital, right? So I think we are going to continue to see this type of consolidation as these pressures keep playing out. We're going to turn to Q&A in a little bit, but I want to give some time for our panelists to close out. I think I'll turn it back to Sophia of, it's been really helpful to learn about like what are these issues, and now I want to see like where do you see the most hope or momentum right now at the national and state levels of how we are curbing consolidation, and how do you see community organizing fitting into these types of campaigns and broader advocacy campaigns?
Yeah, so I think I will say, so in a very difficult and painful moment that we were living through, including on healthcare costs, right? We have this new reality of this bill that Congress passed earlier this year that's going to be making the biggest cuts to healthcare in history. And so there's a lot to be very, in terms of healthcare, there's a lot to be really worried about. But I will say the national movement on affordability, affording your health insurance, has really like turned a corner, I think, over the last several years. That, you've got 20 million people and counting in medical debt. You've got the vast majority of people, regardless of their political affiliation, saying that they can't afford their care, that they think the government has a role in lowering healthcare costs and figuring out why healthcare is so expensive. And you've got a very rare area on the national stage in Congress where there is actually bipartisan agreement on the problem. Everybody agrees that consolidation is running rampant in the healthcare system, almost everybody. And there's a set of solutions in the short term that the last Congress actually was able to pass some legislation out of the House because of all the national momentum and the work and the broader movement that's growing. Now, it didn't get over the finish line, but there is still a lot of momentum at the national level to start to make national policy change to rein in consolidation among hospitals in particular, but in other sectors, and on drugs, on insurance companies. So there's a growing recognition, and I think that's because of the community organizing. That is because of states like California that have been on the front lines and establishing an Office of Healthcare Affordability and looking at trends and healthcare costs across the country and the disparities that exist in that, and in states across the country. So I think there's a lot of momentum, and there is a lot of hope that the fight, like healthcare affordability, like it was bad before, it is only going to get worse now. It's not to make light of it, but it's like, let's not waste a good crisis. Like there is a real moment that we have to put on healthcare, that we have to hold elected officials accountable. And the community organizing is a central piece of that. We heard, I think, on the panel this morning and throughout the day, like we can have the best policy ideas in the world, but if we don't know how to navigate through the political system, especially in this moment, we're not going to make progress. And I think on healthcare, and this might be a little bit controversial, but I think, one of the things we're talking about on the national level is if we want to be in a place where we can fight nationally for more coverage expansions in this political climate, we have to address costs. We have to address what's driving costs, and we have to bring forward actual solutions and organize and build power bases and coalitions around those solutions that we can get those changes enacted in Congress and in states across the country. And so there's a lot of states who are on the front lines of that, and there's a national movement that folks can plug into. CPEHN has been Unite Here, their national and locals have been involved at all levels. But I think that's really what it will take, is a lot of coalition building, multi-stakeholders with big power bases of people and small businesses and labor, organized labor, doctors and nurses who are in these systems who are so frustrated, right? They're losing their jobs. they're working overtime, they're, and they're working their butts off, and they're not, being rewarded for how hard they're working for the communities because of the C-suites and the management of the systems that are being forced to work into. So there's a lot of momentum, a lot that can be plugged in, and then we just got to keep going. Keep going.
And Ian, from the labor side, what does it look like to hold hospitals and insurers accountable, these organizations accountable, and maybe what lessons can community advocates take away from organizations like unions that have been in these fights?
Yeah, as you can tell from my accent, I'm not from this country originally, so I tend to think big about what is possible, and I've negotiated, we have members in Canada. I've negotiated contracts at hotels in Vancouver and Toronto where a basic health plan is universal for everybody, and I can't describe how different those negotiations are. Now, a Canadian style system might be a million miles away from the political reality of where we are today. I actually think there's a pathway. It will take a decade or two, but I think there's a pathway. And one thing I really want to see is for us collectively to stop playing defense, just playing defense against the Trump budget bill and the Trump cuts and policies. Let's use this moment to go on offense and take kind of the bold steps that I wish we'd taken previously, and we really urgently need to now. California's created this Office of Healthcare Affordability. One of the rules that the board has set, and I sit on the board, is that healthcare companies of all sorts are not supposed to spend more than 3.5% more next year than they're spending this year, and there's going to be an enforcement system. It's a big experiment. I don't know how it's going to pan out exactly. It's an experiment. It's a gesture towards shifting incentives away from driving revenue growth. But we need a lot more. On consolidation, we need to give the state the ability to say no to mergers and acquisitions that are going to drive up prices. We came close last year, I think it was. We need to get there. But more than that, competition only goes so far, and we're not going to just build lots of new hospitals. We shouldn't build lots of new hospitals when the hospitals that exist can meet the demand for services. We need to start experimenting with setting prices in the commercial market. Oregon is doing this for public employee health plans. That's a great start. Let's do that for all commercial health plans. Setting a fair price for hospital services, for physician services. And once you've done that, you could do that for insurance plan rates as well. Drugs are much harder because the federal government, the laws preempt a lot of what the state can do, but there's stuff that we can do to rein in pharmacy benefit managers and so forth. The state is a big purchaser of healthcare itself, not to forget Medi-Cal and forget the public health services for the millions of Californians who work for the state and their family members. That's a lot of purchasing power. The state could drive, say, to a common statewide formulary of drugs and organize the state's health plans around the lower cost drugs that are just as effective. So I think if ever there were a time to take some risks, now is the time to do that, not just to play defense, but to persuade people, working class people who are abandoning progressive policies for the whatever you call Trumpianism, to show that we're actually able to deliver in moments of crisis. And healthcare absolutely is in a crisis for working people. It is the biggest, most progressive tax on working people that there is. It takes so much bigger share of working people's incomes than rich people's incomes. It doesn't need to be that way. And if we don't take these steps, I mean, there are millions more people who are going to lose coverage above and beyond HR1, the budget bill, as my union is no longer able to negotiate the kind of money we need for health benefits.
And then Lynette, so the story of Madeira isn't over. What is MCCJ focused on now, and what advice would you give other community groups about getting involved in this type of struggle, staying vigilant and keeping your local hospitals and providers accountable?
Well, currently we are, we still are bringing up the hospital. I wholeheartedly believe that I was invited to sit and participate in this panel because I never stopped talking about the hospital. That's something that, I'm invited to, take a mic. I'm probably going to drop Madeira Community Hospital closure at some point. Because it's important that the community see that we're still talking about it because it's still important. We're still at risk. Yes, our hospital opened, but July of this year, Planned Parenthood in Madeira closed down, which we know a lot of our community members thought not only their reproductive care, but just their overall care there. Now, it's important for us to really make sure that the community are really on target with what's on their radar, right? And keeping their involvement and their engagement into these things not only active, but continuing to leverage that relationship that we've built over these 30 years to get community organized in the appropriate way, teaching them the channels of, or going to the powers that be, right? And how to do that appropriately. I wholeheartedly recommend leaning into not only the relationships that you guys have amongst your networks, personally, with the hospital and us trying to be as vigilant as possible. I think it's pretty easy to maybe assume that we don't have the best relationship with our new hospital management, but we have a relationship. And we are working to continue to leverage that by really just kind of being nosy and staying curious and asking the questions and, taking community concerns to, their spaces and holding them accountable. I think that that's really important as a community-based organization is that once you do gain the trust of your community, what are you going to do with it? It's not just providing them the resources and giving them the answers, but what are you going to do when they come to you and say, hey, like, I'm struggling, or hey, this is a concern, or hey, this is what's going on. What do we do? They come back and they want to organize and they want us to activate. So we're like, okay, we got to do this quickly because our community is now saying, hey, this is a concern specifically with the hospital, and there is, and and not everybody's going to always be happy with all of the healthcare and everything that is provided in our county and beyond. But really, what I would recommend is, which I think was my one of my largest learning curves coming into the nonprofit space, was the networking. When I say leverage those relationships, that is something that has really helped tremendously. And it wasn't something that helped just the organization get in to these spaces and take certain seats that maybe weren't originally designated for us. But what it does is it allows the powers that be, and it allows the hospital management to say, okay, they're not letting up on us, which means that the community is not letting up on us, which means that we have an obligation to take care of this community and to serve this community appropriately. Does that happen all the time? No. Is it a flawless system? No. But ultimately what that does is it sends the message to these businesses and to these, I hate saying business and profit when we're talking about healthcare because I think of people. But ultimately what that does is it really reminds these businesses and these for-profit entities that come in and are taking care of our community that you are serving people. These are lives. And unfortunately, we suffer the repercussions of what no longer having that healthcare accessible when our hospital closed down, unfortunately, was inevitable. We lost lives, and we don't want to go through that again. And our community doesn't want to go through that again too. So it's really using your voice and really organizing your community to advocate for themselves as well, because as a community-based and any sort of business that does this, this is your day-to-day. Once in a while, you start having these meetings and these people are like, okay, yeah, we know the coalition. They're always talking about something and they're always mad at us for something. But when your community is coming in and your community is saying this and your community is addressing these people appropriately and your community is not letting up, that is when we have noticed that there is change. And I wholeheartedly believe that is why our hospital opened up as soon as it did, because we really worked with our community members to engage with our politicals, to ensure that they know that there are people who are suffering in this community and you guys need to do something about it. So, you know, as I would say, this a small guy in this conversation, it's really empowering your community and empowering those voices and letting them know that yes, you're suffering, and yes, the impacts, unfortunately, they hurt, and these are things that might be a lot larger than what we feel we can do or is at our capacity, but reminding them that we're not just victims in this. You have to speak up, you have to voice your concerns, and you have to learn to hold people accountable and doing it the right way.
Thank you. Well, thank you. The panel. I love that you just did a lawsuit, though, like just to get your voice in front of a judge who's deciding over which company is gonna buy this bankrupt hospital. Like it's just, and nobody was thinking about that until you had to force your way in there. So, and thank you, Sophia and Ian. Your perspectives were super helpful to help us explain like why this is happening and what directions we can go in to make some change. And so I'll open it up to questions. Everybody has any questions for any of the panelists? Question?
Yes, thank you very much. I thought that was great. I do a lot of work in this field, and I was wondering about the relationship between community or advocates and these businesses. I call them businesses, and I work in law, and I never think about working with them. It's always adversarial. I don't really believe in changing hearts and minds. It's always like a pretty aggressive approach, but I'm thinking like with more lobbying and policy work that I'm doing now, as any, like, they don't think of themselves as evil, right? They probably have the justification. So I'm wondering, what justifications do you hear from them? And then what are the best arguments, let's say, to sort of get them to see the damage that they do to communities?
I don't know. I'm gonna take that one. Yeah. I would say more than anything, we got a lack of response to answer your question. You know, that doesn't mean that the questions were not being brought forth in the conversations. Just to go in a little bit more into detail on what the coalition did, we did host a series of town hall, the virtual town hall. And our intent behind that was to kind of start the beginning stages of learning of what is a community hospital, a nonprofit hospital, what happens in the event of a hospital closure. And we were bringing in people and during these series to explain this to our community. The end result was because of that, and because we had so many community members that not only were attending virtually, but were spreading it in mass sort of ways where people from outside of our county were tuning in, this really got the attention of the now current owners. And we really leveraged that by saying, hey, you see that our community is interested. They have a lot of questions. Let's host an in-person town hall. Are you guys willing to come? And it was kind of like, you know, back against the wall. They did, and they showed up, and we were very grateful that they did. But one of the things that I would say we really worked with community on is having them understand that when we get opportunities to have, you know, this business in the room, let's really ask the questions that, you know, we need to know. And the responses that we got were, I mean, you think about it, we had like a room of maybe like 300 people, and we were like double capacity. So there was no fire marshal or in the room or in the vicinity because we packed the house and then some. The questions that were being asked, I'm sure you guys can only imagine. You had people in there that were curious about what is it going to look like? And then you had people that were in there that were infuriated because they were representing either a family of, you know, somebody who lost a family member, or, you know, somebody who's gravely ill because the healthcare was no longer accessible. And the answers that we really got, or that community got, it was always this beacon of hope, which it was always, you know, this is what's to come, which ultimately we also, as you know, at that point, we kind of felt like we were the bridge between the management company and the community. We also wanted to go in the direction of what this business was telling us. If this is what you can expect from us, please hold us accountable. So, you know, I don't think that there was a whole lot of sort of like a spelling out of what was to be expected. But ultimately, I think it really was important that we kind of shifted the tones, you know, in the town hall to allow the community to also say, okay, hey, you know what? They showed up. Let's ask those questions, but ultimately, let's also be open to receiving what they're saying. I hope I answered your question, because I can go on and on, but I want to make sure I don't go too far left.
Do you want to say something?
Yeah, I just wanted one other thought, you know, it resonates what you said to me, like power responds to power, and in my world, the day they settle with you is the day they realize fighting you is going to cost a penny more than settling with you. But sometimes there are you can find unlikely allies depending on the fight, and sometimes, you know, maybe a health plan might be aligned with your interests vis-a-vis a hospital or what have you, and sometimes there are some opportunities for very interesting coalitions that you wouldn't necessarily think of.
And if I could just add on, I mean, it's such an important question, right? Because I think it is often an adversarial relationship, because what we're saying is like, we fundamentally disagree, and like your business model is literally causing people in our community, our family members, our friends or neighbors to go bankrupt. And so I think, you know, on the national level, I'll say, like, I don't think it's that it's not an adversarial relationship, right? Like they definitely know where we stand and we don't align on this. But I think to Ian's point about like who's a good messenger, like who else can come to the conversation, and depending on who you're talking to, obviously that changes a little bit. But having, you know, when you bring in businesses, when you bring in employers, when you bring in the aligned health plan, and when you're saying something like, you know, it's both that the prices are too high, and it's just that the business model, like it is a business, right? And so there's a fight that's just like, should we have profit in healthcare? And that's an important question to be asking. And I have a personal opinion about that. And is that the system that we have? And right. And so it's just about aligning the business interests, like the hospital's business interests, with your actual mission, which is to make sure the people in your community are healthy, get the care they need at a price they can afford. And so sometimes it's just about like the angle that you come into the conversation, and coming into it like that is like, I'm not telling you can't make revenue, you can't make profit, but if you're gonna make profit, it better be because no one in your community is in medical bankruptcy, and everybody in your community has the access and the health that they need, that their health outcomes are improving, that all the factors driving their health outcomes are being addressed, that you've got wraparound services, that you have a robust system meeting the needs of your community. And if you have figured out how to make revenue and profit in that.
Oh, yeah.
Sure, I'm so sorry. I'm getting it. And of course. And if you're making revenue in that type of situation and that type of model, then good for you, right? And like that, you know, we can decide if that's something that we can all agree on. But I think that type of conversation can often shift the conversation a bit out of the adversarial and more into the like, well, how do we make this work for everybody involved?
Any other questions?
I wanted to follow up on what you said on an appropriate business model for healthcare. Like thinking about staging rural hospitals and thinking about ways to still take care of these rural communities, but at the same time, knowing that there are all these threats around, like, if consolidation happens, it can also be really detrimental to the care that is able to be provided by the community. I don't know if you all have an opinion on what is an appropriate business model for how healthcare should be carried out in terms of like if a for-profit model, a nonprofit model, a public-private model that exists. What is best given the terms and situations of our system right now, or going forward, ideas of what that could look like.
Yes. Do you want to start?
Yeah, I'm happy. It's a really, really good question. And I think there's layers to that in terms of like, what is the system of coverage, and then how do we want to pay for it? And I think, and then there's also the question that you're asking, which is like at the community level, you're in a rural community in particular, like how do we Like, how do we build a model that is actually going to do this? And I think probably, and I'd be curious what my panelists think, there's probably different communities will require a different model. And what's going to work in a rural community is probably not going to work. The same thing might not work in an urban community. And I think that we're seeing that play out for many of the rural communities, where because the model is increasing prices and generating people coming into the hospital, that you can like fill your beds and then, you know, people leave and you fill your bed and people leave and you're ordering, that volume is not the same volume in a rural community that it is in an urban. So it requires just a completely different solution. And so I think there are ways that you can structure and change public and private dollars flowing into communities to help bolster rural communities in some cases, and prevent against further consolidation. And so that's kind of, I think, you know, and there are states that have done this. There's in Pennsylvania, they had something called the rural hospital, global hospital model. In Maryland, they have something similar, but it's statewide. And so there's different sort of financing and payment structures for hospitals in particular that you can look at to both control how much healthcare costs are growing, bring prices down, and then build in really important measures to make sure that hospitals are improving population health outcomes, that they're providing timely care. And so those are some of the innovations that are happening around the country, and to see like, how do those work in the market?
Anybody else want to answer?
Thank you.
Okay, any question? That's a question over there.
Hi, first, thank you so much thank you CPEHN for putting this panel together. It's my first time really learning so much of this information. So now I have a list of things that I need to go and look into more. I was sitting here thinking, why do we spin and spend so much of our energy within this broken system and not look for something better? And so I got a lot of hope from Ian's remark about there's a way to get there. You see a pathway of getting somewhere else. And so I'm just wondering, from a community-based perspective, even if it's in the next couple of decades, what can we do in community to start to prepare? And I'm taking notes from what Lynette was sharing about ways to do this. But I'm just wondering, as a community-based organization, there are things that we can do to move towards that, even if it takes a couple of decades. What do you see our role being in starting to do that work?
Our collective role, community-based organizations, worker or union organizations together, our job first of all is public popular education. People don't understand just how much money, $550 billion a year we're spending on healthcare in California. And that's shooting through the roof. And think what we could do if we changed that cost curve. We could, for instance, fund long-term support services for the elderly and disabled just by shrinking the amount that's growing. So really educating your community organizations, members and partners. Joining forces in Sacramento is incredibly effective. A dozen years ago, when I started going to Sacramento, legislators, when you said healthcare affordability, they thought about affordability to the state budget. How much is Medi-Cal going up? We shifted that over by concerted organizing in Sacramento, so that, and we have to do some more work on this as new generations of legislators come in, but people really begin to understand more what a burden it is on working people in our communities. There's huge opportunity for that. And then really holding them to account to deliver on some of these incremental reforms that paint a pathway, even if they're not ready to sign up for a state-financed health system like many other countries have. These steps, the building blocks, having an agency that determines what a fair price for hospital services. You can't operate a statewide system without that entity. But you can create that entity and make a radical difference in the short term. And the same is true of many of these other, oversight of mergers and acquisitions and stuff like that. So building, I think the short answer is, let's all refocus on building coalition around this issue.
Okay, Eddie, and then we'll go back. So Eddie, you want to go first?
Yeah, I have a couple of questions for Nina. I know this is an extremely hard things to keep it sustainable. How do you sustain this effort? Because they can come back the next day and say that we decided to close that, it's too much work. And were you able to identify any, I would say, champion or in the legislation that can help you to make sure that maybe if this happened, we can work with the state to take over the hospital or however that's set up, a system that makes sure that people who needed the care will continue to have it if they decided to pull out.
Yeah, we certainly did from the onset. I would be amiss to not acknowledge this. I mean, support is like completely undermining their role. Senator Caballero and Assemblywoman Esmeralda Soria were pivotal in not only ensuring that there was emergency relief for the hospital funding, but constantly having Madera Community Hospital in the conversation. I mean, it's one thing when you have, us on the ground saying this, but when you have your electeds that are talking about our rural hospital and, they're keeping that in mind and they're keeping that in conversation, like Ian mentioned, it certainly does, it makes a huge impact on, the way that, these either funding or, whatever these resources that exist that maybe we don't know, that it gets dispersed with us in mind. The first, I don't remember the first part of your question, like sustainability.
Yeah, like how you even sustain your current efforts, because I feel like this costs money and time.
Oh, for sure.
Yeah.
Absolutely. All of the work that we did due to the hospital closure was unfunded work. It's not, yeah, I know. It's like, what? How did that happen? Yeah, it was completely unfunded. There was no grant that we could kind of tie it back to. We just knew that it was an emergency need and our job is to meet that need. So is it incredibly like something that we have a plan to sustain? At the time, no. Moving forward, there is. I look for grants all the time to see how we can continue, not necessarily this work directly with the hospital, but using that model for other issues that impact our community, such as immigration. And that being something that is really, really prevalent right now in our community. And it's unfortunate the impacts that it's causing on our community. So really, I would say it wasn't sustainable and it's incredibly difficult. It requires a lot of creativity. It requires certainly looking for funding sources. But one of the biggest tips I can give you guys is be as annoying as I am. Talk any chance you get, because you never know who's in the room. You never know who has money to fund that. You never know who's inspired to send the message that, to talk or speak on behalf of the issue that your small community is facing. I highly recommend that, as CBOs, we have to be creative. I would say that's the first thing, and flexible. And with that, you have to use those to your advantage. But yeah, I mean, I would be lying to you if I said that we had this like magic pot of money that it just appeared because, this issue came down. It didn't. But certainly, as a CBO, learning from this unfortunate, because it was really a catastrophe that happened in our community, and understanding that the possibility of it happening again or something to this effect, impacting our community again could happen. So looking for those funding sources and making those connections, certainly, as a safety net. Yeah, unfortunately, I wish I had a better answer, a more, clean answer for you, but that's the reality that we face and that we're currently facing now.
And may I say just an appreciation of you, like the stubborn, persistent
Heck yeah.
willfulness gets you a long way.
Yeah.
And one of the challenges, especially in the labor movement, is healthcare is always the second or third most urgent priority, especially when our members are getting swept up in the streets and in the workplace. It's always second or third. It's really hard to keep that focus. So it's that just stubborn persistence, and I think if we all channeled that, like you have, we'd get a long way.
Yeah, I wish I could record that, tell my mom, because I got in trouble a lot for that as a kid, but look at me now. Thank you.
Get a question in the back.
So there's been a lot of talk in this session about private equity in hospitals, which is really important. But private equity in physician practices is also exploding.
Yeah.
Like from like almost 0% in 2012, something like 15% from like just about a decade ago of like gastroenterology clinics are not owned by private equity. And there was a study that came out of OSU, like Ohio State, like earlier this year, that said that probably a big motivating factor for that is physician practices owned by private equity make about $100 more per claim than physician-owned practice. So I think it's a no-brainer for physicians to go private equity, right? And that's my question. How do we keep physicians accountable for the choices that they make? Because it is hard, because people like their doctors, right? And we're always just like, oh, doctors are like, the providers in the community and they're doing the things, but they are also making choices and they are powerful lobbyists. Like in Medicare Part B, like doctors were allowed to discriminate for 50 years. We did not have the like non-discrimination clause for private physician practices that applied to hospitals because doctors didn't want it. And so it's just like they are making choices all the time and lobbying for these choices that impact our healthcare system, but it is so hard to keep them accountable. How do we do that?
So I'll just say like, totally, like, beautifully said. And I think like part of the challenge with consolidation and private equity is like, it's a little bit like whack-a-mole. You whack it down over here and it merges over there and it pops over here. And that's kind of what's happening with private equity. And you've got all kinds of trends happening across the healthcare markets, across states, across regions. You've got about who works, doctors. About before COVID, most doctors were not employed by private equity or hospitals. Now they are, right? And you see insurance companies like United Health that own most of the doctors in the country now, right? So you see all kinds of market changes happening, and it's all for this reason of more market power and generating, profit. So 100%, just validating everything you're saying. I think it's increasingly become very difficult, especially in this like climate of a lot of mergers and acquisitions, for physicians to remain independent. They're endangered. They're an endangered species. But there's a lot of recognition, I think, I'll say at the national level and policymakers across the political spectrum, that it's important to preserve independent physician practices and to have some alternative to just like every physician works for a private equity company or a hospital or giant hospital system or an insurance company, right? And so, but that's part of the work of what we have to do, right? We're telling the story today predominantly of hospital consolidation and its impact on prices and access to care, but there's a lot of other dimensions of the way that market power is shifting across the healthcare system that's not aligned with consumer and other purchasers' interests around health and financial security. And physician services is right, like insurer markets are consolidated, hospital markets are consolidated, and physician markets, specialty physician markets are increasingly consolidated. And so I think, so that's not a solution, that's just a validation of the problem. But I do think, not to get too wonky, but I do think that there are policy solutions about like, well, what is the best way to pay for healthcare in this country, right? As we're talking about like, what's our vision? Like we have to be against what's happening. We also have to be for the vision of what healthcare in this country should look like. What's the system of coverage and how should we pay for it? What are the incentives that providers should get, whether you're a hospital system or an independent practice, for delivering care? Do you get paid because you just ordered a lot of x-rays and MRIs and you're just turning people in and out? Or are you getting paid a different type of payment that allows you to look across the whole person needs of your patient population and not just address the medical care, but also, and the physical care and the clinical care, but also look at the other factors that are driving your health outcomes? And you have the tools and the resources, because we're paying differently, that allows you to find the wraparound services, bring in the social workers, bring in the community health workers and the CBOs, which are literally like the linchpin to it all, right? And we don't pay that system doesn't pay that way. But I do think that is one of the solutions in terms of like, how do we move forward We have to pay doctors, we have to pay for healthcare completely differently in this country. And there are efforts, there are innovations of that happening across the country. This big system transformation or payment and delivery reform, there's all different wonky ways to refer to it. But there are pockets of innovation happening where in primary care in particular, right, you see this push from primary care doctors saying, pay us differently, give us the upfront money, hold the costs down, take the savings, reinvest it, and pay us differently so that we can be paid for the work that we're doing in our communities on prevention and wellness and promotion and addressing all the non-medical factors that drive health. And there are places in the country that are doing that. I think we need more of that, and we need it across more markets, across more states, and at scale nationally. But I think that's part of this fight in terms of the long-term fight on, how do we build a system that actually meets our needs? And it's not just about corporate greed, but it's about the health and financial security of everybody who relies on it.
We'll do one more question. I think Lourdes, maybe.
I don't know if it's a question. I do immigration services, background in communications. And so like listening to what's going on and seeing around the room, I'm happy that I'm amongst so much youth, so much youngsters. This is like literally what's happening right now is hurting me because I really need to go to a lot of appointments, right? So where's it going for you, right? What's the data saying? I mean, after all, we're talking about businesses here, we're consumers. What's the market data that they're using to see where they're gonna shove us up to? Because I mean, people who are well off and have, their way, they don't even use this system. This is foreign to them to start with. So the system that we are subject to have to use because of where we're at in society is what, is chopping our heads, right? I mean, why can't we tax sugar? If that's the reason why we need hospitals, because we are all diabetic or going there, or we're all gonna be hit harder by COVID, or we're all gonna get harder health risk and acute health issues because of where we work. So, I mean, I think that I would like to know, not only from the market studies that they use, but what do we do right now to start affecting as consumers where we're at? Whether we use the system directly or indirectly, or for the future of us, our future, our kids. So, like a lot of legislation that we're working with having our say, like I just figured out, I just learned about this, as I started working in this about birthing centers. I mean, y'all, whether you have a need or want to have a child, it's crazy, but you really need to have that. And I hear now that there's not even enough places for you to give birth, right?
Yep.
So I think that's bad, but listening to what you're all saying, and I also live in Fresno, and trust me, yes, she is stubborn. She's a good communicator, everybody that has to know about it has to know about it. But y'all looking around each other, you have to see, first of all, who's on your hospital board right now?
Yeah.
Why don't they have a public seat for you to be at that table? If private or nonprofit or whatever, somewhere or another, our tax-paying money as a sales tax, or as a home buyer, as a worker in that county, who is there at that table? What's your county board of supervisor doing for you to make sure that a hospital is serving you or serve your community? I just think that, listening to everything, I was like always assuming everybody was doing their job and making sure holding people accountable. But as consumers, we have so much power. And you have to go and ask that question. And if you only know the mayor, ask the mayor. You only know city council, ask city council. If you only know your pastor, ask your pastor. And the best thing that you could do is, if you have that privilege of having health access and you pay a premium, please go use it. Don't wait till you're old and you lose everything, trust me. And everything gets much more costly, and they have to add bigger amounts of you to fix you, to take care of you.
Thank you. I think we'll close it out there. Thank you, Lourdes. I think we're thinking about look at your communities. We need to do some power mapping, right? You need to think of who's owning your hospitals, where your doctors at, what are the major players, and then how do you start inserting yourself in these conversations, networking, meeting your electeds, meeting your local officials, and how do we start having this conversation? So thank you all so much for joining us. Thank you to the panel again. And I'm sure they'd be more than willing to, answer any questions if you folks have any questions. And then we're gonna take a 15-minute break and then we'll return to the main Solis Hall at 2:45 PM.
And the 2:45, before folks, don't slip out, because 2:45 is where we're gonna like regroup, debrief, and talk about what we learned and what we want to do about it. So just please join us for that conversation. It's really important.
Here?
It's gonna be back in
In the main room. Thank you.